Hi friends, in this series of respiratory system examination, today I will talk about the auscultation. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice and information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Coming to the auscultation techniques of the respiratory system, auscultation is an essential clinical skill for evaluating the chest and identifying the underlying respiratory condition. It helps in identifying breath sounds, which further help to diagnose various lung conditions. We use the diaphragm of the stethoscope, not the bell, since the chest sounds or breath sounds they are relatively high pitched. We should ask the patient to breathe deeply in and out through the mouth. Before that, we should demonstrate this process to the patient to ensure proper breathing in and out. We should auscultate bilaterally and we should compare both sides at similar position for accurate comparison. We should avoid him inducing a cough by asking for comfortable deep breaths. Breath sounds have intensity and quality. The intensity, or we call it as a loudness of the sounds, may be normal, reduced, or increased, and the quality of the normal breath sounds is described as vesicular. Breath sounds they probably originate from turbulent airflow in the larger airways. When we place our stethoscope on the chest, we are listening to how these sounds have been changed on their journey from their site of origin to the position of our stethoscope diaphragm. The normal lung tissues makes the sounds quieter and selectively filters out some higher frequencies, and the resulting sound that we hear is called vesicular breath sounds. There is usually no distinct pause between the end of the respiration and the beginning of the expiration. When the area underlying the stethoscope is airless, as in consolidation, the sounds generated in the large airways are transmitted more efficiently, so they are louder and there is less filtering of the higher frequency. The resulting sounds heard by the stethoscopes are termed as bronchial breathing. Classically, they are heard over the area of consolidated lung in the cases of pneumonia. The sounds resembles that obtained by listening over the trachea means we can compare it with the breath sounds which we listen over the trachea. They should resemble each other. Although the noise there in over the trachea is much louder, the quality of the sound is rather harsh, the higher frequency being heard more clearly. The expiratory sound has more sibilant or hissing character than the inspiratory one and lasts for most of the expiratory phase. So, in nutshell, the normal breath sounds are vesiculars. They are heard over the most of the lung fields and are softer during the expiration. They are filtered by normal lung tissue, creating a sound known as vesicular breathing. Increased breath sounds may be heard in the patients in areas of consolidation where sound transmission is enhanced, as in pneumonia. Reduced breath sounds occur with airway narrowing in patients of emphysema or pleural effusion where the transmission is diminished. Let us discuss about the mechanism of sound production, or we can say normal physiology of breath sounds. In larger airways like pharynx, trachea, the sounds are generated due to turbulence, and the sound frequency ranges from 200 to 2000 Hz. They are heard over the upper sternum. In smaller airways, the higher frequencies they get dampened as sounds travel from larger to smaller airways, and these airways only filter the sounds, not generate them. And the sound frequency ranges from 200 to 400 Hz. They are heard over most of the areas of the lung. Position of the patient for chest auscultation. For anterior chest or front of the chest, the patient should be in sitting or standing in upright position. For auscultating the back or posterior of the chest, the preferred position is the patient should be sitting, leaning forward with their neck flexed and arm crossed in front. If lying down or in recumbent position, we should ask the patient, or we should turn the patient to the side or place the stethoscope under their back to auscultate. We should always ask the patient to breathe through their mouth. If they are not cooperating, we should ask them to cough or count numbers or cough. Then we should observe during the deep inspiration. The breath sounds intensity is graded as 0 to 4. Grade 0 is absent breath sounds. Grade 1 is barely audible breath sounds. Grade 2 faint but definitely audible breath sounds. Grade 3 is normal breath sounds. Grade 4 is louder than normal breath sounds. If we see the graphical representation of the breath sound, the upstroke represents the inspiratory element, downstroke represents the expiratory element. Length is indicated by duration or timing of the breath sounds. Thickness indicates the loudness or intensity, and the angle between the upstroke and the downstroke indicates the pitch of the sound. Smaller the angle, higher is the pitch. The normal breath sounds, they can be vesicular, tracheal or bronchiovesicular breathing. The vesicular breath sounds, they are heard over most of the areas of the chest. Tracheal or bronchial breathing is heard over the larynx and the trachea. They are also heard between C7 to T3 vertebra on the back of the chest. Bronchiovesicular breathing is heard anteriorly in the first and second intercostal space. They can be heard posteriorly between the scapula. These vesicular breathing, tracheal or the bronchial breathing, and bronchiovesicular breathing, they are normal breath sounds. If tracheal or the bronchial breathing or bronchiovesicular breathing, they are heard in the areas other than mentioned here in this slide, then they can be pathological. Coming to the vesicular breath sounds, their character is rustling or breathing. They are higher pitch during inspiration. Inspiratory to expiratory ratio is 4:1. Inspiratory phase is longer than expiratory phase. There is no pause between inspiration and expiration. They are heard over most of the chest. They are louder in the infraclavicular, axillary, and infrascapular areas, and they are diminished at lower margin of the lungs and over the scapula. They are produced by distension and separation of the alveolar wall as the air rushes in. Graphically, the A phase represents the tubular phase of inspiration. B phase is alveolar phase of inspiration, and C is the expiration. Coming to tracheal or bronchial breath sounds, they are harsh or guttural sounds. they are longer and louder expiration. They have longer and louder expiration is there. Expiration has a high pitch. Inspiration to expiration ratio is 1 is to 1, means equal duration of inspiration and expiration. There is also a pause between inspiration and expiration. They are heard over the larynx and trachea. They are caused by air moving in and out through the narrow opening of the glottis. And graphically, they have A and B phase. A is tubular phase of inspiration. B is no alveolar phase. C is the expiration phase. So the B phase, that is alveolar phase, is absent in tracheal breath sounds. Tracheal or the bronchial breath sounds are further categorized into three types of sounds: tubular, amphoric, and cavernous. Tubular breath sounds, these are high pitched sounds. They are heard at the they are high pitched sounds heard at the bronchioles. When there is no change in the sound, it indicates the condition like consolidation, as in pneumonia. They can be heard over the pleural effusion or massive pleural effusion. Amphoric breath sounds are low pitched sounds with high pitched overtones, giving a metallic quality, and we might hear them in pneumothorax, that is open pneumothorax, and large communicating cavities in the lungs. Cavernous breath sounds are low pitched with a hollow or equal quality. They are typically heard over the lung cavity, for example, from a lung abscess or tuberculosis. Bronchovesicular breath sounds, they are mixed between normal breath sounds and the louder bronchial breath sounds. The expiratory phase is louder, longer, and higher pitched than the inspiratory phase, and sometimes it sounds like hollow. Where do we hear them? We hear them on the upper part of the chest around the sternum, that is the first and second intercostal space, between the scapula, that is between third or fourth spine. Sometimes we may hear them over the lung apices, especially on the right side. These sounds, they are produced when air-filled lung tissue lies between large bronchus and the chest wall. This results in a mixture of vesicular and bronchial breath sounds. So they have also three phases. A is the tubular phase of inspiration. This represents a bronchial breathing. B is the alveolar phase of inspiration. It is a normal vesicular sound. The expiration is louder, longer, and often has higher pitch than the inspiration. When it is present, it is a hallmark of it is a hallmark auscultatory finding which can help us identifying the COPD and asthma. Diminished intensity of breath sounds. Breath sounds may be reduced due to issues either in the sound transmission or sound production. When there is a defect in transmission, means problems that block or dampen the sounds from reaching the chest wall. They may include pleural effusion, thickened pleura, thickened chest wall as in obesity or muscular built person, pneumothorax, lung fibrosis. Or secondly, when there is defect in production of the sound, for example, bronchial obstruction, emphysema, respiratory muscle paralysis, all these contribute to diminished intensity of the breath sounds. Coming to added or adventitious breath sounds, added sounds in the lungs or the pleura are abnormal or commonly referred as wheezing and crackles. Initially or in the olden days, we used the words like rails, crepitation, runkai. They were confusing, and we should avoid them using. We should use the words like wheeze or crackles. The wheezes are musical sounds due to airway narrowing. The widespread wheezes, especially heard during expiration, are common in asthma and COPD, and they are caused by the dynamic compression of the bronchi. A fixed single pitch wheeze may indicate a tumor or foreign body heard in different position. We should never confuse wheezing with stridor, which indicates a serious laryngeal or airway issue requiring urgent attention. Stridor is often loudest over the trachea. Crackles are short, explosive sounds. They are likely caused by the sudden opening of the previously closed small airways. Coarse crackles may indicate bronchiectasis, while fine crackles suggest pulmonary fibrosis or pulmonary edema. A pleural dub relates to pleural inflammation. It has a rubbing or crunching sound. Vocal resonance refers to the vibration of the voice transmitted through the chest wall. It is heard as a resonant sound while the patient repeats a phrase like 99. Increased vocal resonance, as in lung consolidation, makes the sound louder and clearer, while decreased resonance is seen in pleural fusion. It makes the sounds quieter. Vocal fremitus is felt with hands on the chest as the patient repeats 99. It helps us detecting the lung abnormalities similar to that of vocal resonance and breath sounds. In consolidation, fremitus is increased while in the pleural fusion it is reduced or absent. So adventitious or abnormal breath sounds can be continuous or discontinuous sounds. The continuous sounds, they last longer than 250 milliseconds and have a musical quality. They are typically caused by airflow limitation due to narrowed airway. The mechanism of production of continuous sounds is narrowing of the airways combined with increased chest pressure, which causes sinusoidal oscillations that produces these sounds. High-pitched continuous sounds are wheezes, a whistling sound often heard in asthma COPD, and low-pitched bronchi. They are snoring-like sounds caused by narrowing due to mucus or obstruction. The discontinuous sounds, they are discontinuous, explosive, non-musical, and harsh in quality, mainly inspiratory, but can be expiratory or both. The mechanism of production of crepitations is bubbling sounds produced by the passage of air. Discontinuous sounds are crepitations, crackles, and the pleural duct. The crepitations, they are produced by passage of air through accumulation or accumulated secretion and sudden snapping opening of the successive small airway when airflow is through it. These crepitation or crackles, they are short, crackling sounds often heard in pneumonia or pulmonary fibrosis. Pleural drop is a grating sound like walking on fresh snow caused by rubbing of the inflamed pleura, common in pleurisy. The continuous adventitious breath sounds, they last more than 250 milliseconds and have a musical quality. They occur due to airflow limitation caused by narrowing of the airways. As the air struggles to pass through them, it creates a sinusoidal oscillation and produces the sounds. So, continuous adventitious sounds are categorized into V's and ronchi, and V's are high pitched. They have a frequency of 400 Hz. They have a hissing or whistling quality, and they commonly arises from small airway obstruction like in asthma or COPD. Ronchi are low pitched. They have frequency of 200 Hz. They have a snoring or rumbling quality. They often arises by air moving through the mucus or secretion in the trachea or large bronchi. Wheezes or ronchi, they can be classified as a monophonic or polyphonic. Monophonic means when they have a single tone Polyphonic means multiple tones can be heard. They can be heard during inspiration, expiration, or both. Monophonic V's, they are single tone sound. They are caused by localized airway obstruction due to tumor, foreign body aspiration, bronchiostenosis, mucus plug, lymph node compression, and polyphonic wheezes. They are diffuse, they have multiple tones, they are heard during both inspiration and expiration, and they are caused by dynamic airway compression seen in conditions like COPD, bronchial asthma, tropical pulmonary eosinophilia, hypersensitivity pneumonitis, eosinophilic pneumonia, Church stroke syndrome. The discontinuous adventitious sounds like reels, crepitation, or crackles, they are non-musical, harsh, explosive sounds mostly heard during inspiration, sometimes in both phases. And I have already discussed the production of the mechanism of crackles, because these are bubbling sounds produced when air passes through the secretion in the airway or sudden opening of the successive small airways when airflow is through it. The coarse crepitation, they are low-pitched, louder sounds. They are caused by air moving through the secretion in the large airway. They are heard during both inspiration and expiration, and they are modified by coughing, can be palpable on the chest. They are seen in resolution phase of pneumonia, early phase of pulmonary edema, bronchiectasis, lung abscess, and bronchitis. Fine crepitations, they are high pitched, they are softer sounds, they are caused by snapping, opening of the small airways. They are heard mostly during inspiration and not modified by coughing, or they are not palpable. They are heard in initial phase of pneumonia, late phase of pulmonary edema, interstitial lung disease, hypersensitivity pneumonitis, and sarcoidosis. The inspiratory and expiratory crepitation. Inspiratory crepitations can be further categorized as early inspiratory crepitation, mid inspiratory crepitation, late inspiratory crepitation. Early inspiratory crepitation are acute and chronic bronchitis, bronchiectasis. Mid inspiratory crepitations are heard in resolving phase of pneumonia. Late inspiratory crepitations are heard in interstitial lung disease, asbestosis, early pneumonia, early pulmonary edema. Expiratory crepitations, they are common in the resolution phase of pneumonia, late pulmonary edema, bronchiectasis, lung abscess, and bronchitis. Some few named crepitations are coarse leathery crepitation. They are seen in bronchiectasis. Velcro-like crepitations are heard in interstitial lung disease. Posture-induced crackles. These are fine crackles that appear when changing the posture. They indicate ischemic heart disease with heart failure. Heard in posterior axillary line after 3 minutes of lying down. Post-tussive crepitation, they appear after coughing and are seen in early pneumonia, early tuberculosis, and lung abscess. Stridor is a high-pitched whistling or grating sound. It is caused by the upper airway obstruction. They are louder over the neck and the chest. They are louder over the neck than the chest. They usually indicate extrathoracic airway obstruction like vocal cord paralysis or supraglottic growth. They are most commonly heard during inspiration but can also occur in expiration if the obstruction is an intrathoracic trachea. Pleural rub is a harsh, grating sound caused by the inflamed pleural surface rubbing against each other. They are heard in both inspiration and expiration but disappear when the patient holds their breath. The causes of pleural rub are dry pleurisy, lung consolidation, pulmonary infarction. This figure depicts the difference between the pleural rub and the crepitations. Pleural rub is heard in both inspiratory and the expiratory phase. Crepitations can be inspiratory, expiratory, or both. Pleural rub is localized to a small area. Crepitation are more widespread. Pleural rub, there is no change after coughing. Crepitation may clear after coughing. If the stethoscope pressure is applied, we may hear the increased sound in pleural rub, but crepitation will have no effect on the application of pressure by the stethoscope. Pleural rub may be associated with pleural chest pain, local tenderness, No chest pain or tenderness is observed in crepitations. Coming to vocal resonance, it is done to check the it is done when the patient's in a sitting up position. We have to place the stethoscope firmly on the chest wall and ask the patient to repeatedly say 111 or 99. We have to compare the corresponding areas in the front, axilla, and the back. Increased vocal resonance is seen in consolidation, lung cavity, bronchopleural fistula. Decreased vocal resonance is seen in pleural effusion, pneumothorax, fibrosis, collapse, asthma, emphysema, thickened pleura. Always remember that in upper lobe fibrosis, vocal resonance may increase due to pulled trachea. The variations of vocal resonance are bronchophony, agophony, and respiratory. Bronchophony is increased loudness and clarity of the sound. It is seen in consolidation just above the level of pleural effusion along the spine up to T4. Egophony is high-pitched frequency sounds. They are amplified, and when we ask the patient, the E sounds like A. It is seen in consolidation, and it is the auscultatory sign of consolidation. Whispering pectoraliqui is widespread sounds. They are heard clearly on the chest wall as if spoken directly into the ear. It is seen in consolidation cavity connected to the bronchus. Other auscultatory features are post-tussive suction. It is a sign of superficial collapsible cavity seen in active tuberculosis when you auscultate a cavernous bronchial breathing, which indicates a cavity. Ask the patient to cough. A suction sound will be heard if the cavity collapses. The prerequisites for post-tussive suctions are superficial cavity, thin-walled cavity. It has to be communicating with the bronchus, and surrounding lung tissue should be normal. Suction splash or Hippocrates suction. It is seen in hydropneumothorax. It is we first percuss the patient and get the air fluid level in the hydropneumothorax. We keep the diaphragm of the stethoscope at the air fluid level. We hold the opposite shoulder of the patient and shake him vigorously. Tickling, tinkling, or splashing sounds will be heard. The other condition besides hydropneumothorax where we can hear the suction splash are large cavity with the fluid, diaphragmatic hernia. These two and hydropneumothorax can produce the suction splash. Coin test. Here we uh, hear the high-pitched metallic or tympanic note. We place one coin flat on the affected side of the chest, posteriorly or anteriorly, and percuss with another coin perpendicularly on it, while simultaneously we auscultate from the opposite direction of the same or affected side. It is seen in massive pneumothorax or hydropneumothorax. Scratch test or scratch sign. It is used for diagnosing pneumothorax. How do we do it? We ask the patient to sit up, place the stethoscope diaphragm on the sternum or the spine, scratch the chest wall from the mid-axillary line towards the sternum. The sounds will be louder on the side of pneumothorax. Hammond's mediastinal crunch. It is a loud cracking or clicking sound near the sternal border, that is third to fifth intercostal space, synchronized with the heartbeat. It is seen in mediastinal emphysema or pneumomediastinum or left-sided pneumothorax. Forced expiratory time. It detects the airflow obstruction. We ask the patient to inhale fully and then exhale forcefully. We have to place the stethoscope in the suprasternal knot and measure the time of audible expiration. If it is less than 5 seconds, it is a good airflow, that is FEV1 oblique FVC is more than 60%. And if it is more than 6 seconds, there is airflow obstruction, that is FEV1 oblique FVC is more less than 50%. Based on the severity, the various findings which are seen in fluid effusion are: mild fluid effusion is when the fluid is less than 300 ml, moderate is 300 to 1500 ml, massive effusion is when the fluid in the cavity is more than 1500 ml. Tachypnea is present in moderate effusion and it is significant in massive effusion, but it is absent in mild effusion. Chest expansion may be normal in mild effusion, decreased in moderate effusion on the affected side, and it is significantly decreased in massive effusion. Tactile parameters is normal in mild effusion, decreased in moderate effusion, and it is absent in massive effusion. Breath sounds are vesicular in mild effusion, absent or bronchial in moderate effusion, or tracheal or absent in massive effusion. Mediastinal shift to the opposite side is absent in mild effusion. In moderate effusion, it can be present sometime, but massive effusion, there will be mediastinal shift to opposite side. Bulging intercostal spaces are absent in mild effusion, present in both moderate and massive effusion. Egophony is absent in mild effusion, present in moderate effusion, and always present in massive effusion. In this in this slide, we can listen to various normal and abnormal breath sounds. This is a tabular form of findings in common respiratory disease, and we can paste or hang this chart in our OPD room and remember, or we can just remember the various findings and the various auscultatory palpatory findings in various lung diseases, and this chart will help us to easily remember the various lung conditions. Maya Angelou has said, when we give cheerfully and accept gratefully, everyone is blessed. With this, I conclude my today's topic on auscultation, and also the respiratory system examination series, which was started with the history, symptoms, signs, and the various examination like inspection, palpation, percussion, and auscultation. I have briefly described all these things in my respiratory system examination, and from next time onward I will be discussing the cardiovascular system examination in cardiovascular series. Thank you. Keep learning.